Good morning, everyone. A warm welcome to the 23rd Indian Prosthodontics Society Postgraduate Convention 2021, held virtually, hosted by Mahatma Gandhi University of Medical Sciences and Technology, Jaipur, India. And I'm really happy to inform you that the day one of the keynote sessions went really well. We had over 2,000, nearly to about 2,000 registrations. And this is a landmark event, first of its kind online for the PG students. And to start today's keynote session, which is being seen live by everyone, we don't have any parallel session today. So that's because we have an international speaker. He's our own. He's an professor, Mathew Kattadiyil. And to introduce Dr. Kattadiyil and go ahead with the session, we have our own two prominent prosthodontists who have served the Indian Prosthodontic Society so well in the last so many years, Dr. T.V. Padmanabhan and Dr. Rangarajan. A brief introduction, though they don't need any introduction. Dr. T.V. Padmanabhan is a well-known, celebrated prosthodontist in India with a teaching experience of more than 30 years. He completed his undergraduate and post-graduation from the prestigious dental wing of Madras Medical College. He received the prestigious scholarship from Japan Dental Association to visit Kyushu Dental University, Japan, a visiting research scholar. He attended advanced training in digital dentistry in Sirona, Germany, advanced implantology training in Zimmer Institute Implantology, Zurich, training on computer analysis on occlusion in Chicago, and trained in magnetic attachment in the Faculty of Dentistry, Tokushima University, and many more. He has served as the president of the Indian Prosthodontic Society, president of Asian Academy of Prosthodontics, and also an executive council member of the Asian Academy of Osseointegration. Currently, he is the chairman of Indian Board of Prosthodontics. He is a diplomat of the ICOI. He has lectured extensively in India and the rest of the world, has over 90 national and international PubMed indexed articles, and has co-authored a popular textbook of prosthodontics, which is a bestseller in India. He has also contributed chapter on porcelain laminate veneers in the textbook of indirect restorations, published by Quintessence. He is a great teacher, motivator, mentor, and a gentleman, and a golfer too. Welcome, Dr. Padmanabhan.
Thank you very much.
Dr. Rangarajan graduated in dentistry from Faculty of Dentistry, Annamala University in Chidambaram in 1998 and completed masters from R. Ahmed Dental College, Kolkata. Currently working as advisor, professor and head, Venkateshwara Dental College, Chennai. He happens to be the first South Indian dentist to receive the diplomate in oral implantology from International Congress of Oral Implantologists, New York. He is the first one to complete fellowship and membership in TMD, orofacial pain and dental sleep medicine conducted by Smile USA and Roseman University, USA in the year 2000. He is the president-elect of the Indian Prosthodontic Society. And we all know him as the longest-serving secretary of Indian Prosthodontic Society. A huge service to this society, acknowledged by everyone, celebrated by everyone. And of course, he's also the co-author of the textbook of prosthodontics, along with Dr. Padmanabhan. Sir, we welcome you with our all our heart, and it's really, we are so lucky that the two of you should chair this session by our own Dr. Mathew Kattadiyil. He is from the US. Thank you, sir, so much for accepting our invitation and joining us today. So I hand over the session to the chairpersons.
Thank you, Dr. Kattadiyil, and it is indeed a great pleasure for me to introduce our speaker for the day, Dr. Mathew. Dr. Mathew received his BDS degree from KMC Manipal in 1989 and also completed his master's in prosthodontics. Educator of the Year by the American College of Prosthodontics. He has presented nationally and internationally, and in addition to authoring multiple peer-reviewed publications, textbook and e-chapters, he is also the co-author of the electronic program Optimizing Success with Complete Dentures, prepared by Loma Linda University in 2013. In 2018, he received the Distinguished Research Award. He is a diplomate and examiner of the American Board of Prosthodontics, a fellow of the American College of Prosthodontics, and past president of the Pacific Coast Society for Prosthodontics in 2019-20. He is a professor and currently serves as the director of the Advanced Education Program in Prosthodontics and as full-time faculty member at Loma Linda University. He is going to speak on prosthodontics education. Where do we stand and where we are heading? Ladies and gentlemen, Dr. Mathew Kattadiyil.
Thank you for the kind introduction, Dr. Rangarajan. It's good to see you, Dr. Padmanabhan, and Dr. Padiyar. Thank you for the kind invitation. And I want to recognize President Akshay Bhargav for hosting a wonderful virtual program, which I know under these circumstances is a very significant accomplishment for the postgraduate students who learn this knowledge that they are going to be receiving in this convention. It is also really heartwarming to be invited by my friends to this convention, and I'm very grateful for the opportunity. And with my communication between Dr. Padiyar, who is the scientific program chair, I was able to glean that he wanted me to talk about the U.S. education, kind of not compare, but just look at how the educational standards in prosthodontics in the U.S. So what I'm going to hope to accomplish is to just give you an oversight in the time that I'm allocated about the educational standards here and how that compares or reflects with that in India, and maybe pique curiosity and some ideas. And that's all what we're going to do today to expand the mind, and hopefully now it goes back to its original dimension. Like Dr. Rangarajan kindly introduced me, my background is the dentistry from Manipal, MDS, in the same school under Dr. Kashyap Bhargav. And then I was an assistant professor in Manipal, the College of Dental Sciences, and it was in 1994. That's a little bit of trivia for you. I met Dr. Padmanabhan, who was an external examiner, and we were both fledgling prosthodontists. This is almost 30 years ago. And we had a good time, and that friendship has sustained. So it's great to see you, Dr. Padmanabhan, and I'm glad to see all the accomplishment and the things you've done in the profession. I did my certificate in prosthodontics in Loma Linda, and then did my Master of Science. And then now I'm professor and program director in Loma Linda University. I have this habit of staying in the same place for a long time, and so I'm still here about 25 years later, and I probably hope to be here for a while. So the topic I have is prosthodontics education. Where do we stand and where are we headed? And to find some meaning for both the postgraduates and the educators that are present today, I had to dig deep and to figure out a way to present this information without making it too boring. And so I hope I'm able to accomplish that. I have no conflict of interest to report. And my presentation outline is going to be about discussing the graduate education, training, and goals in the United States. And I'm going to provide some examples of patient treatment presentations for prosthodontic specialty board examinations, which is a big deal in the US. And I'll highlight the importance of why that is. So, and then provide perspective on how educational requirements align and differ between India and US. And finally, a brief discussion, but pretty much a bullet point on emerging trends in prosthodontics. And I believe that will dictate the standards and the way education is going to progress in our countries. So just to give you an idea of how dental education standards are set in the US, I want to briefly introduce the concept of CODA. CODA stands for Commission on Dental Accreditation. Think of it like the Dental Council of India. CODA's job is to be a national accrediting agency for dental and dental-related educational programs at the post-secondary level. And they have an accreditation process, which is pretty vigorous, and they evaluate the quality of dental education programs every 7 years. These programs include pre-doctoral programs as well as advanced dental educational programs. The commission also implements standards, and the whole idea is to promote and monitor, and that's the key word, the monitoring the continuous quality and improvement of dental education programs, very similar to the role played by the Dental Council of India. So to define what a prosthodontist is in the US, basically, if somebody completes a prosthodontics program in a CODA accredited dental program in the United States, they're considered a prosthodontist. You don't have to do a master's to be considered a prosthodontist. You can finish your certificate program successfully, and then you are considered a prosthodontist. So in the advanced program in the US, usually the program is 3 years in duration. It only gets extended if the student has a delay for whatever reason. And if you complete a research project, you can earn a master's degree. So the difference between India and the US is in India, you have to do an MDS, which always includes the clinical requirements, the didactic requirements, and then you top it off with a research project, which is defended and then approved by a body of your peers or your faculty, and then you get your MDS. Here, you could graduate from a prosthodontics program with no master's unless you finish a thesis topic, which is then defended. If you were to want to do a maxillofacial training, you have to choose a program that offers it, and you have to stay back 1 more year. Unlike, again, in India, where I actually did a lot of maxillofacial prosthodontic treatment and came nowhere close to doing that kind of training in the US, because that would require an extra year in the US. Students and residents here must have the didactic clinical background that supports successful completion of prosthodontic specialty board examination that fosters lifelong learning. That's a philosophy that I take with me every day to school. It is not about what I teach my students today. It is the habits that I create or help them create that will be lifelong engrams of muscle memory that makes them great leaders in the future. I can tell you for a fact that all of you who are postgraduate students who are studying, whatever you are studying now is currently applied, might not be anywhere close to what you're going to be applying in the future. But this background that you're going to get from your faculty and your program directors and your heads of departments is going to give you the training that fosters lifelong learning. And that's what's going to make you leaders of a specialty that takes pride in calling itself the quarterback of dentistry, which means that we control what is dictated by other specialty, because in the ultimate look of things, we are the ones seeing the patient when they graduate, when they finish their treatment in the clinic, and not the surgeon. It's always the prosthodontist that end up seeing the patient last. And so we have to quarterback a lot of this for successful completion. And for that, leadership is important. So let me give an example of student research for master's degree in the US. We do provide funding, and I would imagine it would be the same as that in India. There is a maximum limit. Nobody is going to give them an unlimited amount of money here to do research. In fact, the money is limited enough that students get very creative and are encouraged to look for external funding to be able to do meaningful research. The interdisciplinary collaboration is encouraged. What I mean by that is instead of inbreeding between prosthodontic faculty and graduate students, we encourage students to seek experience from other departments, including perio, implant, prosthodontics, and then also spread their wings to the medical school. And we do not really encourage multi-center studies because there's a lot of paperwork, and it's only for the reason of time that we don't encourage that pursuit. But interdisciplinary collaboration is definitely much sought after in every program. Master's degree can result in extension of the program. Unlike in the MDS program in India, here, your certificate program, usually if everything is done on time, will finish on time. But research is fickle business, as some of you might have already realized. where the sample size doesn't really come in time for you to finish on time, and you end up extending your stay, and that is perfectly understood, and the student is allowed to stay back to finish the master's degree. So I want to give you some examples, some studies that some of my graduate students have published. Raj Swamidas, that you see on the screen here, finished this program a few years ago. He has some really recognizable names on his study, and he sought them out because of the specialty in the implant realm. Dr. Khan and Dr. Lozada are well known to you, as well as Dr. Goodacre. And he did a study on abutment screw torque changes between the straight and the angled screw access channels that came out pretty recently. Dr. Rami Amoon did an interesting study where he looked at intraoral scanners and looked at it from tooth preparation design and the angle of the scan to see if there was any deviation in accuracy. Again, his committee is different, and the only quarterback of this committee is the program director, and usually the other people change based on the degree of expertise that they offer. On the bottom left now, you see a second-year grad student. This is not even his master's topic, but he used this publication or his research as a precursor to his actual research topic for his thesis. And he's studying the reverse torque values using different tightening protocols. If you really look at the literature, there is no one recommended tightening protocol that one person says is the best. Different companies offer different options, and your faculty might tell you this is the best way to do it, but there's no consensus on how to get the best torque and preload with the tightening protocol. And so this is an interesting study, and I'm hoping to see some meaningful results when he actually publishes his thesis. And finally, a study that is kind of dear to my heart because it's the first time we went out of prosthodontics into the medical realm. We collaborated with a faculty who's an MD and a PhD on the topic of molecular biology. And we looked at, the serum levels and compared it with the frequency of relines. And this student actually received a significant grant to do the study, which is about $50,000. In Loma Linda, that is big money, not for some NIH-funded school. But she was able to do a very nice project, which actually got some recognition from the editor of the JPD, Dr. Rosensteel. Just to give you an example of why these publications are meaningful to the student, because obviously it earns them recognition. The program loves it, as well as the school, because that enhances the reputation of the program, and it is definitely encouraged here in the US. I want to just compare the Dental Council of India examination process, and this is based on material that I received from Dr. Pariyar and some conversations, some of my friends who are program directors in India. The first year written exam and all examinations are conducted at the end of the first year, and then you have a final year written exam and a clinical examination. If I recall correctly, that was the same thing I did when I finished my master's program in India in 1992. It was a 3 essay and a final essay, which is a 1 essay situation, which is kind of mind-numbingly tense for me, and I got lucky, and I found a topic that I actually had read up a few days before, which happened to be on nutrition. I still remember that. And in India, the MDS is a requirement. In the US, there is a slight deviation when the examinations are held. There is no final examination to become a prosthodontist. Every quarter, which is you think of it like this, a year has about 4 quarters, which is 3 months each. So at the end of every quarter, there is an examination. So for example, if you're taking a course in microbiology, there is a final examination at the end of the quarter, and that is it. You're pretty much done with microbiology for your whole duration of your program. There are clinical requirements, just like you have in your own programs. There are, there are patient presentation seminars where you will present your treatment plans, your treatment progress, and maybe even your completed treatment. There are mock board examinations that help you prepare for the specialty board examinations. So the difference is there's a continuous assessment going on, but there is really no final examination that culminates the program. You can opt to leave the program with a certificate, and you can call yourself a prosthodontist. If you do a thesis, like I said before, you can get a Master of Science or a Master of Science in Dentistry. Clinical requirements vary among programs, and you might be wondering, how does it compare with what you do and what we do here? I don't think there's much of a difference. Just for context, I provided some information for what we do here in the US, and this will vary among programs. Commission does not prescribe that this is the exact number that you have to do to be able to graduate from a certificate program. Each program has their latitude and flexibility to make that decision. For example, here we have a 60-unit minimum requirement. Most of the students end up exceeding those requirements, and anterior aesthetic restorations about 10 units, removable 12, and most of the students blow that out of the water. I'm even considering erasing that. Partial dentures, 6 units, and I'll tell you why that number is low, and it continues to become lower in the U.S., and I'm thinking it's probably the same in India as well. Immediate dentures, 12 units. Implant prosthodontics is becoming more and more a player in prosthodontics, and the specialty introduced placement of implants in prosthodontics a few years ago, and now surgical prosthodontics is become part and parcel of the specialty. And we encourage implant prosthodontics in every program in the U.S. that does prosthodontics, includes fixed complete dentures, overdentures with attachments, single tooth replacements, fixed partial dentures. Not that many, so that's why you don't see a high requirement. And their students are encouraged to place implant at least a minimum of 15, which is a very low number. But keep in mind that these are minimum requirements that programs dictate. And there are others, knick-knack stuff like occlusive guards and relines and repairs that I haven't included in this slide. So there's a part of the specialty that is different from how it is in India. Once you finish a prosthodontics program, your journey doesn't really end there, and you're not going out into the world to practice prosthodontics, even though you can. You are definitely encouraged to pursue specialty board examination. And though it's optional, it's very much encouraged. And I'll outline the reasons why. First of all, it signifies qualification and achievement beyond formal training. If you want to separate yourself from the herd, this is the way to do it. As soon as you become board certified, I see my students walk a little bit more straighter, feel a little bit more confident, and they feel like they can hang with you in the professional and the academic world. And that is a tremendous amount of inspiration for the graduate who passes the board. Defines and validates the specialty. When you become board certified, you're actually doing the specialty a favor. The more board certified people we have in the profession, it actually makes the specialty look stronger. It also recognizes those that meet or exceed exceptional expectations. You're showing that your caliber of dentistry and your specialty clinical expertise is a slightly higher level than what the rest of them bring to the table. Public awareness is increasing. So in the US, people actually look up to see if you're board certified to make sure that you have a certain basic level of competence that they can expect from a board certified person before they come and visit your practice. And some of the students that I have, a lot of them are international students. They go back to their home countries. If they want to get promoted, if they even want to get a better salary, they have to be board certified. So sometimes I don't even have to force students to become board certified. It is in the culture of the program that as soon as they set foot, the culture dictates that they all plan towards getting board certified. And it also provides assurance that the dentist has the appropriate knowledge and skills and experience needed to deliver optimum care in a specific area of dentistry. Ultimately, board certification to me is your willingness to be humble, present yourself before a group of your peers, and be examined by them. And these peers have undergone the same process that you are now subjecting yourself to, and then you come out of it validated. It actually makes the specialty stronger. So the way I'm combining this presentation is by focusing on the examinations to kind of go towards what the educational goals are. Because after all, if you look at what you have to do in your examination, that kind of tells you what the program needs to teach to be able to get you there. So I'm going to talk about the American Board of Prosthodontics, which is the specialty organization in the US that certifies individuals. So it's called the board certification process. It consists of 7 people at a time. And so we are elected. I happen to be a board examiner right now. We are elected by our peers who are all diplomates of the American Board of Prosthodontics for a 7-year term. After the 7-year term, we rotate out and the next person is replaces that person. So You're not there for more than 7 years, even though you could be invited as a visiting examiner for another 7 to 10 years. But it was only 7 people, and it actually is a dynamic rotation that happens over a period of 7 years. So I am exiting out of the board in 2025, and I'll be replaced by somebody who will be elected in 2025. So what does the board certification process entail? If you are a graduate of a US accredited prosthodontics program, you're eligible to take the board. Any 2 parts of the 4-part exam can be taken in the 3rd year of the program. So similar to your MDS examination, you can take 2 of that examination, but to become board certified, you have to graduate and then challenge 2 parts of the program. So there's a 4-part examination process. You can take 2 parts within the program, and then the other 2 parts could be immediately after you finish the program. So let me give you an example of what this 4-part examination process looks like. Section A is very similar to your first year written exam and your final year written exam, except these are multiple choice exams. And we call it a written exam, but it's completely multiple choice. Section B has 3 parts. Part 2 would be an RPD with 4 crowns. Part 3 is a fixed full mouth reconstruction with at least 6 units on natural teeth, and the rest of them could be on implants, but you need a total of 14 units. Part 4 is a complete denture, complete overdenture. It could be a CD obturator in one arch, restoring the opposing arch. You must demonstrate bilateral balance occlusion. So that tells you that one arch has to be a removable prosthesis, because that is the only occlusion scheme that you can then employ for that specific situation. So Section B has 3 clinical parts, and you could take Section A, all the 3 parts, and pass your boards. But because it's not easy to find patient situations for all 3, the board has provided some avenues where you can be a little bit more flexible with your choice. So Section C is like your oral examination, like your viva that you experience in your final exam and your 3rd year, the first and the 3rd years. This is a very standardized 20-minute 3-part exam. So it's a 1 hour of calibrated question that you have to answer with a specific timeline, and then you are scored using very standardized criteria. Section D is a recent addition where, to recognize the implant placement part of the specialty, we are encouraging candidates to bring the implant placements, and we have specific criteria for that. A minimum of 2 dental implants, and you will present your patient situation. You'll be grilled on the patient situation, and then you'll be asked 20 minutes of questioning, which is also standardized. So you have a wide array of options here to choose from. So you could do pathway 1, could be you take the written exam, which is a common denominator. You have no ways about not taking that. And then take all the 3 parts of the part B, and you'll become board certified. Or you could take Section A, take any 2 parts with your oral examination for Section C and become board certified. Or you could take Section A, Section B, 2 parts, and take your implant section with your Section D and become board certified. You cannot take Section C and Section D together and claim that you've taken 2 parts. It's either or. And each candidate must complete at least 4 dental implants supporting fixed restorations in one or any combinations of patient treatments within the examination. So the 4-part examination, you have to have that requirement met, which is why you'll see in one of the examples I'm going to show you, a CD opposing a fixed CD with 4 implants is an easy way to meet that requirement, and a lot of students will pursue that option. So Section A examination will look very similar to what your first year examination would be, except this is delivered after when the 3rd year of the program or later if the candidate delays the application. We have it in testing centers, so you can go to a testing center, and there are about 150 candidates each year compared to probably 600 every year in India. It's a 4-hour examination, 200 questions, all standardized. Not that they're all perfect. If they're not good, we look at it statistically and we throw out the bad ones and bring in new ones. And it is distributed among what's called major categories, which includes implant dentistry, fixed prosthodontics, removable prosthodontics, biomaterials, and there are minor categories, which includes evidence-based dentistry, wound healing, pre-prosthetic surgery, TMD, aesthetics, pharmacology, perio, and others. So that is how the examination is distributed. This kind of gives the student an idea what the emphasis on your preparation should be. And I don't think it's any different from how you prepare for your written examinations there, except some of your examinations are essay or short essay format. So I'm going to give you some examples of the ABP examination sections. And the whole idea is not to get you involved in the ABP process, because that is not the intent. The intent is to kind of give you an idea where the education stands here in the US, how that reflects in India, and for you to make your own decisions as to where things can improve. There are a lot of educators in this group here who can make meaningful change, and I can also discard something that you say that's not going to be working over here, and that's not realistic. So I just want to give you a preamble to what I'm going to show you here. I'm going to show some photographs of what some of my grad students presented before the board, and they all passed it, so I can show you that these are acceptable patient situations. I'm not including all the photographs that I'm going to show that the board requires. I'm not following even the specific format of the examination. And keep in mind, the students are expected to bring diagnostic, definitive, and duplicate costs to the examination, which is a stressful thing if you think about it. For you, the examiners come to your home turf. Here, the students bring and pack everything in the airlines, catch a flight, go to Chicago or wherever the examination is held, and then that stress of having to pack all this and take it safely so you can show it to your examiners is kind of recognized by the board, but that is still the way we do things now. This is only intended to convey how the certification examination reflects the expected training in an accredited prosthodontics program. It is like this: if you know what the examination is asking, that means that kind of tells you what is it that the program is expected to teach. So this is an example of a complete denture opposing a fixed complete denture presentation. Dr. Al-Halal was my previous grad student. So he inherited a patient from a senior resident who had places implants and had provisionalized his patient with an interim maxillary complete denture opposing a mandibular fixed complete denture, which is referred to as a conversion prosthesis, as it was converted on the day of surgery. So he starts his presentation from this point, shows the occlusal view of the edentulous arches, the maxilla and the mandible without the fixed prosthesis, interim fixed prosthesis. You have to show a photograph of the patient in approximate occlusal vertical dimension from the frontal view. You have to show the border molding like you do in India, and I know this because I've done it. You have to show a pristine border molding, and you are evaluated based on your photograph, though, here, whereas over there you are actually doing it in front of the patient and showing it live. To show your final impressions. Since the mandibular arch is a fixed prosthesis, you're not required to show a border molding because there's no purpose in getting that extension. However, we would like to see the anatomical landmarks, such as the retromolar pad, captured in that impression so that you can use it for determining the occlusal plane and height of the mandibular prosthesis. You're not required to capture set relation in any fancy method. This is a student who is just wanting to show that he has got some skill sets that he wanted to show the examiner with some Gothic arch intraoral recording. I know you do those recordings for your MDS examinations. We did it when I was a student. And however, the board does not prescribe that specific route to get to where you need to get to. You could easily have a patient swallow or lift their tongue to the back of the throat and guide it into centrigulation, capture the record, and that is also acceptable. It is more the destination than the journey itself that is of interest to the board. So the students are expected to do their lab work, and this is done by the student themselves, but of late, because of the significant shift towards digital technology, which all of us are experiencing. I saw the introduction by Dr. Panoramic of the two moderators in this session. They already have invested so much of their experience in learning digital technology, and that reflects the way things are going in the future. They're not spending the time to become experts in this field for without a reason, and the reason is everything is shifting towards digital technology, and we recognize that. So now the board does not want you to do all these wax patterns. You could send it off to your lab tech and get the same work done. But however, this was done by the grad student because this rule was not in effect when he took the board exam. So you do your wax patterns, you cut back, and then you have to send it to the lab for milling or printing or casting your framework. It doesn't matter what it shows, but the fit of the framework is important. And then you do a trial placement again with your final festooning photographs. You have to show the intaglio and the cameo surface of the maxillary and the mandibular prosthesis. And these are all separate slides. I just put them in one group just for convenience. And you're analyzed based on your impression. So if your final definitive cameo surface, intaglio surface of your maxillary denture doesn't look anything like your impression, it's going to get flagged. So students are very keenly aware of it, so they'll make sure that the impression is as pristine as is the trimming and final finishing of your prosthesis. Balance occlusion is an interesting topic, and I'll explain why in a little bit, but we require the student present balance occlusion in their part 4. And it is not because the board says balance occlusion is the absolute end all and be all of complete denture occlusion. That shift is happening already. But we want students to show and demonstrate a skill set that they know what a balanced occlusion scheme will look like and why that can be applied to a patient, and how it's applied is important than the fact that every patient does not necessarily need balanced occlusion. You document everything with intraoral photographs and cast, which are mounted on a programmed articulator, and that is brought to the examination. So I'm not going to show all that. And so here is an example of all the photographs you're bringing to the board exam. You have to show the MIP view frontal, right protrusive view frontal, right lateral, left lateral, and all the right and left protrusive MIP working and non-working movements to show that you have whatever occlusal scheme you're prescribing here. Balance occlusion can include bilateral balance, or it could be lingualized occlusion. So you cannot bring a monoplane occlusion to the board examination, because we are not saying that monoplane is a bad occlusal scheme. The board does not think it requires the skill sets that you would need to balance a denture. So post-treatment should show a panoramic radiograph. This is to evaluate the health of the implants, as well as kind of get an idea of the fit of the framework. And a PA can also be provided. And then the post-treatment photograph of the patient, smile and repose, and profile view, just to kind of have us assess the mentolabial angle, the nasolabial angle, and the overall occlusal vertical dimension. So that is an example of a part 4, which is a complete denture opposing a fixed CD. And with this requirement, the student fulfills the need for 4 implants restoring a fixed unit, because the fixed complete denture is a fixed unit. So most of the students will gravitate towards this kind of a prosthesis just because they can get that requirement out of the way, in case your part 3 does not have implants. So part 3, like I said before, is a full mouth reconstruction. This is done again by one of my grad students, Dr. Rani. And all the photographs are pre-treatment photographs. It includes MIP, smile view, occlusal views, protrusive, same, right and left, lateral and non-working views. And the whole idea is to be able for the examiners to get an understanding of what the pre-treatment condition of the patient is and was. You have to show pre-treatment radiographs. You have to show panoramic radiographs of the pre-treatment. And then you have to show your diagnostic waxing at the proposed occlusal vertical dimension. It can be in wax. On this student who wanted to just impress the examiners, he actually scanned it and actually printed out his diagnostic wax pattern in resin. And that's perfectly okay too. You have to show your provisional restorations. I'm just keeping the frontal view here for convenience, but you have to show the lateral and protrusive views as well. You have to show your tooth preparations. This is where it gets really exciting for all the program directors in the group. And you're looking at the total occlusal convergence. You're looking at the ferrule effect. You're looking at the foundation restorations. You're looking for caries. That's what we look for too. That's what you as a clinician should be looking to avoid as well. You have to kind of meet the guidelines for what a tooth preparation should dictate for the tooth you're preparing. And like I said before, you have to have a minimum of 14 units. You have to show the occlusal view. You see some gnarly looking discolored tooth structure, and you have to be able to defend that is not caries. And the board will trust how you defend it with, but you have to be confident in your defense. If you also look carefully, you can see all the amalgam looks new. That's because the students are required to replace all the old foundation restorations with new ones. if you leave an old foundation restoration saying that it looked good, there's a good chance that you might not make it for the examination. And by the way, this is not again about the examination. This is about inculcating in you a standard that will allow you to get great outcomes. And that is the message that I'm sending today to you. It's not about how the board examination happens, but what the process entails you to become, and this should also inspire you to also achieve the same kind of results that some of the students are able to get. Again, right and left lateral views. You can make an impression with PVS, and most of the graduate students who come to the examination or candidates who come to the examination will make the impression in polyvinyl selection. And most of them will use a custom tray, and you know the literature that kind of supports it. You can also scan it, like this student who is technologically a little bit more advanced and confident. He scanned his impressions as well. And you can scan and take your CR records using the scan, but ultimately you are required to bring mounted preparation cast with all the tooth preps like a die prep so that we can evaluate your finish lines and your total occlusal convergence and your reduction of each tooth just to be sure that you met the criteria. And then, of course, the post-treatment photographs, your occlusal view of the post-treatment, maxillary and mandibular, frontal in CO or MIP. At this point, CO should coincide, maximal intercuspal position, a protrusive view, right and left lateral, MIP, right lateral protrusive, right medial protrusive, left MIP, left lateral protrusive, left medial protrusive, and frontal protrusive, right protrusive, and left protrusive. Now, keep in mind, we're looking at this photographs and we're looking at the cast, and there's no way that if you find an interference that is not going to be left uncalled and asked about. So the respect for occlusion is big, and as fledgling prosthodontists, the graduate students should recognize how critical occlusion is and how it separates you from the rest of the general practitioners out there, because it is the little details that helps these restorations last a longer time. And that attention to detail that you inculcate in your specialty, that you learn in your specialty, is going to make you a better dentist in everything you do in dentistry. And of course, when you finish a full mouth reconstruction, if you want to protect your investment as well as the patient's investment, most of the time it's always a good idea to prescribe an occlusal guard just so that they don't wear down the ceramic or break or fracture this porcelain. You have to show your post-treatment radiographs, both PAs or FMX full mouth radiographs and panoramic, and then you have to show a before and after. So I just spent a little bit more time on a part 3 examination because it's a full mouth reconstruction. It has so many nuances to it that I'm not even gone into. There's a script that the students read from, but also there are questions that are asked so that the examiners kind of know whether the student understands the concept of why this occlusal vertical dimension was increased or restored, and how that restoration happened, and what is the basis for it, and how was that transferred to the patient's mouth, and how did that end up as a good outcome for the patient. So this is a RPD exam, and like I said, removable partial denture presentations on the board is becoming very low. So I had to dig deep, and this is actually my board examination patient. This is 20 years ago. I just thought I'll present that. And so I was looking for a part 2 because those days we didn't have an option to go with the section C. So basically placed a 5-unit FPD on 2 canines to meet a requirement for 4 units, and then made a maxillary impression and then a mandibular altered cast impression, which those of you who are in the 2nd or 3rd year would know what that is all about, and an altered cast from that impression. And then you have to show your final festooning, and all of it has to be done by the candidate at that time. And your final result, frontal and then occlusal view, and then your post-placement photographs. So now the requirements are still the same, but I see students doing less and less of removable partial dentures. How does the examiner grade the student in an examination? And it could be similar to what you experience, or it could be slightly different. For the board exam, you bring your patient situation to the board, you present your case, and the examiners ask you questions, and they use specific criteria to decide whether you pass or fail. If you pass, you pass. There's no more conversations after that. If the two examiners decide that you have not done well in the examination, you do not automatically fail the exam. You have the two examiners take the documentation of the reasons for failure, present it before the whole board of 7 people, and the board collectively votes anonymously to determine the result. And your name is also anonymous. So the whole idea is to prevent any bias from determining the outcome of the examination. The Section A, the written examination, the Section C, the scenario examinations are criterion-based examinations. So we send it for statistical evaluation. And we have a professional group that gives us statistical analysis and even tells us which examiner was grading tougher and which examiner was grading a little less tougher. And not that there's anything wrong with it, but it kind of balances out the whole scenario in the sense that for the final outcome is more favorable and more fair to the student or the candidate. So again, let's take a look at the DCI, prosthodontic examination process, which I'm not comparing to the American board examination process, but these are the two meaningful examinations I feel are worth comparing. You have one pathway. There's only one way to get there, and you have to do that, or you're not going to be successful. The American board allows you multiple pathways, though if you think about it, the destination is more important, but the pathway, even though it's slightly different, they're not all that different. Your examinations are on site, which you should be very grateful for, because your examinations are taking the time to arrive at your site to present, allow you to present your patients to the board examiners or your examiners. Here, we are asking them to come to us. We are also traveling to this remote site, but the examination is held in a remote location, and that makes it a little bit more difficult to bring all the cast and the models to the board exam. You have multiple written examinations. Short and long essays are great. I actually think that if you really want to know what a student knows, ask them to write. But it is very difficult to standardize it. So for that reason, the board actually prescribes multiple choice examinations, and they're not perfect. And we throw out what we think are borderline poor questions on. If some of them are too easy, we throw them out as well. So it's a dynamic process where we add new questions based on the trends in prosthodontics, and we take out bad questions or old questions. The DCI examination is very prescriptive. You know exactly what you're supposed to do in your clinical examination. You got 3 days. You have to prep some teeth. You have to show your final impression. You have to set some teeth, and you have to design an RPD. This one is less prescriptive. You could bring your patient presentation. You should know all about it. You own it. And you're showing photographs. There's no last-minute surprises that could happen other than the questions that are going to be asked. Or if you miss something that was very, very pathologic or incriminating is not a great word, but if you see some cement there in your final restoration, you're pretty much done. That is not acceptable in a board presentation. So you could make a mistake there, but you are still in control of your destiny in that sense. So now to shift towards major trends, because that is another part of where we're headed that I want to address. Is there a paradigm shift in prosthodontics? If you look at just the board examination itself, look at part 2, RPD. This is October 2020 and April 2021. 4 and 3 candidates, compare that with the fixed and the complete denture and the scenarios, you see the number is pretty minuscule. Look at implant treatment, that's pretty low too, but that's because it's recently introduced. So RPDs, is it a dying specialty or a dying discipline of prosthodontics? I'm not sure of that, but I see lack of interest in it, partly because of implant dentistry becoming such a game changer, and patients also don't want to wear removable prostheses. If you look at the pass rate, because that's what as postgraduate students you're thinking about, how do they do? These guys, are they passing? But the pass rate is pretty good. A written exam, 90% pass. Again, full mouth reconstruction, 80%, part 4, 85%, section C, 80%. Part 2, again, not so great, 71% only pass. And the section D is a recent exam, so I would not take the 95% too objectively, but that gives you an idea of the pass rates. So where are we headed with removable partial dentures? If you look at RPDs, the design concepts, I mean, It's a rich history of removable partial denture. With all those big names, Kattadiyil, Crawl, all of them contributing to the literature with their unique philosophies and ideas for stress relieving class assemblies. I truly enjoy the innovativeness of removable partial denture giants. The techniques have evolved with the altered cast technique, and materials have changed. So this is a photograph of a wooden RPD with ivory teeth, and this is from the National Museum of Dentistry in Baltimore, from Maryland. This is probably 1850s when this is made. This is a swaged gold framework with porcelain teeth, probably in the early 1900s. And then is the good old vulcanite RPD with porcelain teeth, in the mid-1950s. This is still being used. And then you have the conventional cast RPD or the contemporary cast RPD, and now if you actually go to PubMed, which is your one way of looking for published articles that are peer-reviewed, and you put in removable partial denture, if you look at this, 1964 to 1995 is the heyday of removable partial dentures, where you can see that the graph is pretty high. About 8,000 articles between 1945 and 2021. This is only to make a point. This is where RPD was really popular. Now, if you add in the word digital and RPD, you can see everything shift towards 2021. In fact, 2014 to 2021 is when you see a significant shift in the way digital dentures are being made for RPDs. Digital RPDs are being made. What does that mean? Everything has gone from casting to printing or milling. So there has been studies that looked at accuracy of CAD/CAM fabricated RPDs. This is a group that published that milled RPD frameworks were comparable in accuracy with your cast RPDs, but not necessarily the printed ones. So there's a lot of accuracy to be still improved upon with the digital technology. Just because we are switching to digital and just because a computer has of this planning of a single implant placement in number 3-6 area, and he has to show a virtual wax pattern, and then he has to deliver the implant as the same way it was planned, and to be able to show the proof of that placement in a periapical radiograph, which is similar to what you're expected to do in your programs as well. So what are the common reasons for failure? And the reason, again, I put this here is because life is not that different between the worlds that we both live in. Diagnosis and treatment planning, and I'm sure your program heads of departments tell you that every day, is the critical difference maker between a good treatment outcome and a poor treatment outcome. There's no point in doing a great treatment and then finding out there was a systemic disease that was completely overlooked, and now all the implants are failing. So diagnosis and treatment plan is where usually candidates don't do too well. And inadequate impressions. I saw a presentation yesterday where there was emphasis on why it's so important to make beautiful impressions. Inadequate occlusion, balancing interference on dentate patients, and lack of balanced occlusion for complete dentures. Inadequate understanding of techniques and materials. Failure to refer when appropriate. One of the things as a specialist you have to learn early on is if you need to refer, don't be shy to do that. If you see a pathology, don't try to cure it yourself. I will use that to earn some friends. Refer to my pathologist friend. Refer to my oral surgeon for a biopsy. And that's how you build teamwork. And if you fail to refer when appropriate, so if somebody needs periodontal therapy and you're not referred to a periodontist and you still manage to restore the patients despite all the periodontal issues, that's going to be a failure. Tooth preparation. Of course, needless to say, the base height ratio, the total occlusal convergence, all of that are important. But most students fail because there's inadequate ferrule effect or reduction. Poor RPD design. Veneers with the dental margins, which literature has shown are not going to be long-term and sustainable. Where crowns are indicated, the student brings a veneer that could be a reason for failure. So what are the notable changes and modifications that you see in prosthodontics in the US? Students are no longer required to do laboratory work, and that's reflected in the examination too. We introduced a new section that focused on implant placement and restoration by the candidate. It's become a standard in prosthodontics. Surgical prosthodontics is here to stay. And I think prosthodontists are the best people to place implants because we are restoratively driven and we know that we have to deliver the prosthesis at the end of treatment. So the worse your placement is, the more difficult your life becomes after the placement. So I see my students spend time and significant effort working with other specialists who are surgeons to try and get the implant in the right location. They get it, and you guys get it, because if you don't get the implants placed in the right location, it is a lot of acute dentistry from you as a prosthodontist to make this restoration work. Digital technology is definitely encouraged, but we are not making it a requirement because not every program is offering a lot of digital expertise. And all of us had to deal with this COVID pandemic. I know you had your programs cut short, probably some requirements were reduced. Some of you are not able to finish some of your thesis on time. Nothing has changed over here in the US. This is still the same environment which we lived in last year. So we were, just to be kind to the candidates, we offered a remote examination for Section C. So they were coming in like Zoom through, like I'm through Zoom right now, taking the examination. And we did that for 2020, and we did that for April of 2021. In October, we're going back to the on-site exam. The reason is we're not trying to be cruel. We are trying to keep the sanctity of the exam. If you release these questions too much, then the board has to sit together and make all those scenarios. It takes a lot of time, a lot of effort, and a lot of calibration. So what are the major trends of the years? Is there a paradigm shift in prosthodontics? This is a photograph of one of my students who's playing with the XNAV guide with Nobel, and she's just practicing on a Typhon, and she subsequently did it on a real patient. Wasn't too excited about it, but she tried. And the digital technology is going to become better and more refined and more convenient. So what excites me with digital technology is the accuracy is getting better. That is the one thing about digital workflow. It's always going to keep better. I'm very hesitant to say, oh, this is not working, because tomorrow, while I'm saying it, some guy who is an engineer has already figured out how to make it better. Improved programming possible for virtual articulation. My biggest beef was you can never program your virtual articulator. You cannot put your condyle guidance. You cannot put your lateral condyle inclinations and program your instrument. Now they're letting you do that. You can actually program your instrument. You can actually get the occlusion that you would like for your patient on a virtual realm. Diagnostic capabilities are now being introduced with the intraoral scanning. The properties of materials are getting much better. And with milling and printing, it's exploding into a whole different world of exciting possibilities for you as fledgling prosthodontists. Implant dentistry has always been the game changer. It still continues to be. There was a young lady I saw about 4 years ago. She fell down 18 feet when she went hiking, broke her maxillary anterior teeth, some mandibular teeth. And there's no way an RPD is going to give her the quality of life. It could give her the aesthetics that an implant prosthesis can give her. And then with the way the fracture happened, these implants are facially inclined, but the angles were able to be corrected with this angulation correction channels that some of these companies provide, and make it screw retrievable, which is so important for somebody like me who's a program director, because once the student leaves, the patient comes back, I'm dealing with the situation, and I would like to know that I can remove this prosthesis, even though it looks great now. Later on, if that ceramic fractures, I would prefer that it's a retrievable prosthesis than a cemented prosthesis which I have to cut down to remove. So prosthodontics is also about not planning beautiful restorations, but also having an exit strategy. I always ask my graduate students, what is the exit strategy if this thing fails? If this restoration fails, you've cemented it, how do you retrieve it? And if the answer is I have to cut it out, then let's look for a better option, because you want to minimize the inconvenience to yourself and the patient. Let's look at complete denture fabrication. Materials, concepts, and techniques have got so much better. Hardy cutters is a thing of the past. It used to be very popular one day. Vulcanite dentures, again, the mid-50s, very popular. Barron's occlusion, introduced by Boucher, very much a great occlusal scheme and still used in contemporary prosthodontics. Polyvinyl selection with the modified selective pressure technique is still applied. The polymethyl methacrylate with its more and improved properties, with beautiful looking denture teeth, with again better properties, makes the complete denture prosthodontics really exciting. If you look at complete denture on PubMed and look at how many publications there are from 1910 to 2021, you look at about 15,000 publications. A huge number of them are from 1965 onwards. But it has sustained over the years. And if you put in digital denture, you'll find that it shifts, like everything digital shifts. But you see that there is about 900 articles now on digital dentures, and that interest is climbing. And 2002 onwards, it's been significantly higher. We have done studies on digital dentures. This is a conventional set of dentures we made for the same patient, and that's on the right side is a digital set of dentures. We actually compared between these two dentures to see which ones patients liked, which ones students liked, because they were the ones who were making it. And we had published an article that said these are some of the advantages of digital or computer engineered complete dentures. This is 2013. We just assumed this would be the advantages. And in 2013, we said that it's great to have this 1 to 2 hour appointment process, and the denture is ready in the second appointment. It really never worked out that way. There's no 2 appointment denture process in the US now, because everybody's realizing without a trial placement, it's a tremendous leap of faith to order a denture and have it come back looking completely different from what you expected it to be. Less clinical chair time provides the opportunity for a more cost-effective, appropriately accurate complete dentures. Very true, and still probably stands the test of time. This is a good thing. You can store all your data, archive it, and if your patient needs a spare set, you could easily order one. A new replacement denture can have the exact fit as the previous denture, requiring less patient adaptation, which is again a good advantage with digitally programmed or digital complete dentures. The denture base is presumed to be superior. That was 2013 when we wrote that, because our philosophy was based on the fact that all the polymerization shrinkage is completed. You're now milling a block of resin. There's going to be no problem with fit, and that has actually stood the test of time. There has been studies, some of them done at Loma Linda, some of them done elsewhere, that proves that the fit of these prostheses are better than a conventionally processed complete denture. But then I have some points to add to that later. What are the disadvantages of digital complete dentures? You need to learn some new procedures. Yeah, you have to use a dimensionally stable and temperature-resistant material because you're going to ship it to a company. Most of them are shipped to a company in Arizona. Some of them are shipped to a company in Los Angeles here in the US, and then Europe, the same thing. During the shipping, there's that distortion happening. Now, some companies are allowing you to mill your own prosthesis in the lab if you buy a milling machine. The 2 appointment protocol does not include a trial placement. One thing about prosthodontics is we are OCD by nature. I'm not calling anybody by, I'm a little OCD. I just do not trust what I'm going to place in somebody's mouth till I try it in. And that physical aspect of trying that prosthesis is something that is lost in a 2 appointment process. And guess what? All these digital denture companies offer a 3rd or a trial placement appointment because they realize that some of these prostheses are coming back with unsatisfactory responses from the clinicians. So we compared digital and conventional dentures in a pre-doctoral setting at Loma Linda. We got 15 denture patients, asked students to do 15 conventional and 15 digital dentures and asked them how they liked it. They loved it because they didn't have to do lab work. And dental students do not want to do any lab work, and they all love the process of making digital dentures. And Loma Linda, actually, the pre-doc students are doing digital dentures. However, look at the underlying portion down below. They were all done under faculty supervision. Because there was a study going on, it was myself, Dr. Jackie, or Dr. Goodacre, or Dr. Baba, who was specifically standing side by side, walking the student through the whole process. Yeah, that's a great way to learn, but then can they duplicate that when they go out and do it on their own? Easier said than done. We have also published on clinical and quality assessment. This is a publication 2017. Look at the number of articles in 2016-17 that qualified for a systematic review, 5 articles. And then in 2018, we published on some of the errors associated with complete dentures. And I would encourage the graduate students in the audience to look it up. And the PMID numbers are provided there for your convenience. We did an update just recently where we stand now with digital complete dentures. And if you look carefully, you'll find there are now 56 articles that met the criteria for qualifying for systematic review. And our conclusions were milled complete computer engineered complete dentures provide superior adaptation compared to conventional CDs and 3D printed CDs. No question about that. However, the improved adaptation did not result in superior patient satisfaction and clinical experience when compared to conventional or printed dentures. So you'll hear a lot of digital denture companies saying their fit is superior. They would be right. But then 6 months later, the patient doesn't seem to appreciate that better fit. So there's a regression to the mean that could happen. There's increased retention. There's better material properties. However, the material properties do differ between manufacturers. So again, it was pointed out yesterday, I was listening to some of the presentations. When you look at peer-reviewed publications or publication, look at the conclusion based on the inherent bias that the presenters might have in what they're trying to convey to you. The milled dentures have better color stability. How many of your patients have really complained about the color vanishing over a 5-year period? Not many, but yes, they are more color resistant though. It can reduce chair time and overall cost. And you do need a trial placement appointment. There's no way around it. Patient satisfaction is not significantly better for computer engineered complete denture when compared to conventional fabricated CDs. So if you're sitting there feeling, oh, I'm not experienced with complete dentures that are made digitally, don't feel bad about it. Because not only the fact that they're not that better yet, the fact is your foundation that you're learning in impression making, can get around impression making. A lot of people talk about scanning impression, but the mucostatic impression is still not going to beat the beautiful border molding you achieve with your final impressions on a completely edentulous patient. You should be appreciative of the fact that you have program directors or heads of departments that are inculcating the importance of basics, and that basics will stand a long way in helping you prepare for the digital future. What's happening in dental education in the US is sometimes these basics are being overlooked, and they're going straight into the digital world, and they're kind of lost in the translation. And so that is something that you should, as educators, look into when you make that transition. Changes in dogma will continue in prosthodontics. There was a recent publication by a group of prosthodontists in the Journal of Prosthodontics on occlusion. I would encourage, again, all of your graduate students to look up this special edition of the Journal of Prosthodontics. There was one in it on complete denture occlusion that I want to just point out. Gary Goldstein, Kattadiyil, and Campbell published this. They start off by saying the occlusion scheme required for an edentulous patient is controversial. Gone are the days when balanced occlusion was the only way to do things. They now tone it down a little bit, saying, yeah, it's still better to do balanced occlusion, but there's no specific reason you should do it for every patient. Most likely for the prosthodontic diagnostic index of type 3 and type 4 patients, which are the extremely resorbed ridges. So people are beginning to recognize the science that we know from 1950s, and the evidence that was mostly opinion is now shifting towards more evidence-based dentistry and based on research. So as graduate students and as educators, you have to kind of start exploring within the constraints of the science and looking outside the box to see what is it that you learned that really doesn't make sense anymore. So where are we headed? Digital technology will dominate your workflow. You cannot get around it. You're already exposed to it. You're planning your implant surgery is all digital nowadays. And soon artificial intelligence and robot-assisted surgery will be knocking on your doorsteps. And I'm not saying it's going to happen tomorrow, but within 5 to 10 years, this is going to be more a requirement and necessity because it's going to overtake a lot of things. Implant-assisted prostheses will increase in usage. Nobody's wanting to have removable prostheses. They would want it to be anchored with implants. CAD/CAM fabrication will become more popular. It's already popular. Printing will become even more popular as a more effective, cost-wise option. Milling is expensive. Further strides in genetics and tissue engineering, and I'm talking about dental-related genetics and tissue engineering, where you're actually growing teeth and hard bone. Again, sounds unrealistic, but this is something we put it in a report to the American to the Commission on Dental Accreditation from the Prosthodontic Specialty that we expect that this change is going to happen in the future. It won't happen tomorrow, but there are people there trying to accomplish this. Biomaterial properties will continue to improve. Environmental impact is becoming a popular topic. Is milling good for your environment? Is printing good for your environment? I talk a lot about digital dentures. And some of the questions I get from especially the environmentally conscious people in the audience is, what is the impact of this on the environment? And I was like, what does it matter? Because that is my attitude towards the environment when the whole thing started, till I started reading up about it, and leaves a fine residue that is, nobody knows where it goes. And we know the impact all of this is having on the environment. And so I'm having a more nuanced approach to this, but it'll become a factor, and some of you will be doing studies on it. However, the key point is the basic principles and techniques will still need to be taught. And that is the foundation of prosthodontics, and you cannot get beyond and away from it. Your trends should dictate your educational requirements and standards. So wherever we are going should be where we should be taking our students, and that can only be driven with the examination process and with the standards. If you examine the students to the standards, then they will follow. I want to finish my presentation by just giving my gratitude to Dr. Kashyap Bhargava. He was my program director in Manipal, one of the finest educators I know. Our relationship started in 1990 when I joined as a grad student. He told me to come to Loma Linda, and I blindly listened to him. It's turned out to be the best decision of my life. He was a faculty here in Loma Linda, and our relationship continued along with his beautiful wife, Kusum Bhargava, who also passed away recently. And I just wanted to dedicate this presentation to Dr. Bhargava, one of the finest educators in prosthodontics that I know. And on a happier note, greetings from Loma Linda. These are my grad students. They wanted to say hi to all of you. And here's my email address. If you have questions that you're shy to ask today, please send me an email. And thank you. What you see here is the photograph of the Good Samaritan statue, which embodies the philosophy of Loma Linda, which is to make man whole and help others. If you look at the straight, it's the medical center. Towards the left is the School of Dentistry. Dr. Padu has visited the school, and he knows it well. So on that note, I wanted to thank all of you. I don't know whether I've extended my time, but I thought I kept myself fairly to my time I was allocated, which is important for all of you, and I get it. I want to thank you again for the opportunity.
Excellent presentation, Dr. Mathew, Professor Mathew. Though I would like to call you by your first name. Hi, Mathew, how are you?
Call me Mathew, that's so much better than...
That's true. But fantastic presentation. I'm so excited about the fact that you spoke so much about the board. As the chairman of the board of prosthodontics, of the Indian Prosthodontic Society, I'm so excited. I'm so thankful to you for enlightening about all these things and giving the importance of board certification. This is going to really motivate a lot of listeners to come up and take the examinations in the board. And you have also given us a lot of information regarding how to go about with the, examinations and how to section them, A, B, and C, and things like that. So very informative. And I still remember when I visited you in 2013, you gave me a presentation of almost the same thing, but I think it was less elaborate. It was not a 1, 2, 3, and 4, but it was just much lesser than this. So we adapted that and then followed in our Indian board also. And it is very informative. I'm so excited. I'm very thankful because this will be extremely motivating for the next generation of prosthodontists, especially the students, because in our board, we have allowed the students also to take the part 1 examination, the multiple choice questions. So I have one question from the audience. This is from Dr. Ashraf Ali from Annamalai University, who's the head of the department. Is it possible to apply the principles of selective pressure impressions with the digital complete dentures?
Okay, that's an excellent question. The answer is with digital complete dentures, if you're going with a completely digital workflow, and I don't believe in that completely digital workflow for complete dentures, you can do what is called a mucostatic impression. If you remember Harry Page, 1934, he talked about this utopian theory of mucostatic impression where you could capture the impression with no pressure. Now, 70, 80, 90 years later, it has arrived. You scan the arch, you are actually getting an impression of the arch without any force. However, that critical aspect of border molding still is lost in the translation. Now, there are people that are in the lecture circuit that say they can scan the maxillary arch, get great retention. And they also claim they can scan the mandibular arch and get great retention. However, when I ask them this question, can you get up in the morning and say, I'm going to scan the mandibular arch to get a good impression? Can you do that predictably? They say, I don't know, maybe, maybe not. It's case dependent. So to answer Dr. Ali's question, there's nothing wrong with mucostatic impression, except the border molding is not going to be happening as pristinely as the ones that we do with our border molding, and then your selective pressure technique. The selective pressure technique does not mean that border molding is important, but that selective pressure technique also places some pressure on the soft tissue. As far as the differences between the two, I don't think there's been any studies that looked at long-term effects as far as bone loss and what happens to the soft tissue. I don't think there would be any change. But to achieve mucostatic is still difficult. It's like reading tea leaves. You make your impression with a scan, and then you have to kind of figure out where the borders are. And some of the digital companies are doing it, but I don't do it because I don't want my residents to start doing stuff like that and then having to go back to the basics. Start from the basics, and then as they get more flamboyant and more experts in this, maybe they can pull it off, but not in all patients.
Very true, very true. That also vouches your last few slides, which says basics are absolutely important. You cannot change the basics. You're absolutely right, Dr. Mathew. You're fantastic. And regarding this board certification, United States, can non-United States citizens or people who have not been educated take up the examinations? Is it possible at all?
At this point, no. The Canadian board allows the U.S. students to take the Canadian boards, but the U.S. board, U.S. is not yet opened the borders to outside U.S. training yet. But
all right.
Things change.
All right, fantastic. So your contribution to prosthodontics and the board is so very extensive. As the chairman of the Indian Board of Prosthodontics, I would be seeking a lot of advice and help. Please, to extend your help in certification programs and then modifying the things. I'll be contacting you quite often regarding this. Please do, because this we are very young. The Indian Board of Prosthodontics is a little young. We have hardly about 8 directors, and all of them are certified. And then we need to move on and motivate more people. So your lecture today, I should say that you have done almost about 100% of whatever that I wanted to do. Thanks to you, Mathew. And can I call upon Dr. Rangarajan to add anything if you have?
Absolutely wonderful, Dr. Mathew. Really, it was a pleasure listening to you, and really opened our eyes to many things. As Dr. Paddu said, the Indian board. And of course, there is, a major difference here I see between the people. The reason why they take up the board exam could also be because there is no exam in the certificate program in the master's level. Whereas here we already have an exam. And also in the American board, I think they are being trained for the American board in their certificate programs and in their master's program itself when they are doing it. They are also getting a training there. Whereas that does not happen here. We are oriented more towards the MDS exam rather than to an Indian Board of Prosthodontic exam. So a lot of insights, and also, as Paddu said, the focus on prosthodontics has always got to be on the basics. There is absolutely no question at all about it. And that's what we harp on for our postgraduate students also. Learn the basics, and then you can, there is infinity which you can achieve later. So I think they excellent messages, and thank you so much for your time. And really wonderful to meet you in person. Really appreciate it. Thank you.
Likewise, and thank you. And Paddu, it's so nice that you reached out to me, and I enjoyed communicating with Dr. Pariyar, who's now become a friend. And it's nice to meet you.
Hey, Mathew, I have to tell you that one statement of yours, exit strategy, fantastic terminology and excellent concept, because as you say, as the program director, you don't know what is going to happen because you're going to be stationed there always. Students come and go, but patients come and eat your head. So exit strategy is a lovely thing, and a lot of the heads of the department from our country will also start thinking in this particular strategy, how to plan and things like that. So lovely, Mathew. Thanks for everything. You have been so lovely to us. Thank you very much. Thank you very much.
Likewise.
Padiyar, sir?
Yes, sir. Thank you, Dr. Mathew. And
I'll see you.
we'll project your certificate, and it will reach your hometown soon.
Okay.
Thank you so much.
Thank you.
And I thank the chairpersons for moderating this session wonderfully. I think we achieved our objective of this lecture, not 100%, 200%. And thank you, Dr. T.V. Padmanabhan.
Thank you.
And Dr. Rangarajan.
Thank
It's
you.
always a pleasure. Thank you, and we hope to see you in India soon, whenever it is. And thank you again.
Okay.